Bismillahirrahmanirrahim. Assalamu alaikum everyone. This is Dr. Mubasshra, and in this video I have come up with a structured approach to chest X-ray interpretation. The purpose of this video is to make chest X-ray interpretation as much easy as possible. This video will be useful for all the medical students, including MBBS undergraduate students, house officers, medical officers, as well as postgraduate residents. So please watch my video till the end to learn chest X-ray interpretation step by step. Many candidates fail their talk station because they miss simple findings on the chest X-ray. Today I will show you how to read it step by step. In a chest X-ray, structures that are less dense appear dark or black, for example, lungs, and structures that are more dense appear white, for example, bones and tumors, and structures with a medium density appear gray. First and foremost thing that you will look on the chest X-ray before its interpretation is whether inspiration is adequate or not, because you cannot comment on the poor inspiratory films of chest X-ray and pathology may remain hidden. Here on the left side it is a chest X-ray with good inspiratory film. However, on the other side it is a poor inspiratory film. So, for good inspiratory film, following should be visible: 5 to 6 anterior ribs, both lung apices, both costophrenic angles, and lateral ribs edge. Standard chest X-ray demonstrate features of PA view, that is postero-anterior projection. Chest X-ray AP view is performed when patients are unable to mobilize easily. Let me explain a clear systematic approach in interpretation of chest X-ray. The method recommended to be used in medicine for chest X-ray interpretation is ABCDE method. A is for airways, that is trachea and bronchi. B is for breathing, that is lung fields. C for circulation, that is heart and vessels, especially pulmonary vessels, heart borders, and aortic knuckle. D is for diaphragm, and E is for everything else, for example, bones and soft tissue. So, in medicine, we interpret the chest X-ray from inside to outside. Let's discuss this one by one. For trachea, look for any sign of tracheal deviation, that is towards the right side, towards the left side, or the position of trachea, that is central. Normally, the trachea is either centrally located or slightly deviated towards the right side. Tracheal deviation is seen in large pleural effusion, tension pneumothorax, and lobar collapse. In pleural effusion and tension pneumothorax, trachea will be deviated towards the opposite side, while in collapse, trachea will be pulled towards the side of collapse. Then comes the Hilar structures. These include pulmonary vessels, major bronchi, as well as lymph nodes. Hilar enlargement can be unilateral or bilateral. Unilateral enlargement can be seen in malignancy, while bilateral enlargement is seen in sarcoidosis. To interpret the lung in chest X-ray, divide each lung in 3 zones: upper zone, middle zone, and lower zone, and then look for abnormality in each zone. Abnormalities in the lung fields can be in the form of consolidation, tumor, mass, or malignancy, or it can be in the form of cavity, collapse, pleural effusion, pneumothorax, and pulmonary edema. Consolidation on the chest X-ray is a term which is used to describe air in the alveoli. It is interpreted as homogeneous opacity in the lung field. It can be present in any of the 3 lung zones and can be associated with a horizontal fissure. The most common cause of consolidation is pneumonia. Rounded consolidation with a well-defined clear border can be due to malignancy or underlying lung mass. Cavity in the lung can be visible as a well-defined round cavity. Its most common cause is tuberculosis. In pulmonary edema, the common findings may include bat wing appearance, that is air space opacification, or hazy appearance of the lung fields. There can be curly B lines, pleural effusion, that is, blunting of costophrenic angles, and fluid in the interlobular fissures. The common causes of pulmonary edema include left ventricular failure, mitral regurgitation, and fluid overload. Pneumothorax is interpreted as true black shadow in the lung fields, which is actually air trapping in the pleural cavity. It is accompanied with collapsed lung. Pleural effusion is the fluid in the pleural cavity which is interpreted as homogeneous or true white opacity at the lower zone of lung associated with meniscus sign and obliteration of costophrenic or sometimes cardiophrenic angle as well. Lung collapse will be seen in association with some lung condition, for example, pleural effusion, lung mass, or pneumothorax. There are other lung abnormalities as well, like for example, hemothorax, which is collection of blood in the pleural space. Empyema is collection of pus in the pleural cavity. Another abnormality which can be there in the pleura is pleural plaques, which is often mistaken for malignancy. It is secondary to asbestos exposure and generally requires no treatment. Next is the cardiac size. Normal size is less than 50% of the thoracic window. When cardiac size, that is cardiac shadow, is more than 50% of the thoracic window, it is called as cardiomegaly. Chest X-ray AP view exaggerates the size of heart. So accurate assessment of cardiac size requires chest X-ray PA view. There are different causes of cardiomegaly which may include valvular heart disease, coronary artery disease, pulmonary hypertension, and congenital heart disease. Also look for cardiac borders on the chest X-ray. For example, right heart border is made up of right atrium mainly and left heart border is made up of left atrium and left ventricle. Then look at the diaphragm for any flattening or raised diaphragm. Raised diaphragm can be seen in various conditions, for example, lung and abdominal issues, phrenic nerve problems, or even pregnancy, while the flattening of diaphragm is seen in COPD. Typically, right hemidiaphragm is higher than the left hemidiaphragm. Now coming towards the very important thing in the exam, that is how to describe the findings clearly. Let's take an example and suppose that in exam you get the chest X-ray of pleural effusion. When describing the chest X-ray findings of pleural effusion in an exam setting, it's very important to be systematic, clear, and focused on key radiological signs. So the key chest X-ray findings in pleural effusion that you will describe to the examiner is that this is chest X-ray PA view of adequate quality. Trachea is central. There is homogeneous opacity in the right lower zone with a meniscus sign indicating fluid layering in the pleural space. There is also blunting of right costophrenic angle which is consistent with pleural effusion. Diaphragm is elevated and partially obscured on the right side. No air bronchogram is seen which supports the diagnosis of pleural effusion rather than consolidation. Cardiac silhouette is preserved and there is no mediastinal shift. Left lung appears clear. Also, there is no evidence of bony abnormalities and soft tissue appear unremarkable. So, my findings are consistent with the diagnosis of right-sided pleural effusion. Now, I ask a question from all of you that what is the hardest finding for you on chest X-ray? Comment below. Thank you so much for watching. Please like, share and subscribe to my channel for more tips and informative content. Stay blessed. Allah Hafiz.